Hi everyone, and welcome to our module on Parkinson's, Huntington's, and movement disorders. So in the module on the basal ganglia, I talked about how the basal ganglia's job is to inhibit the thalamus and keep it from creating unwanted movement. So when the basal ganglia fails, you get movement disorders where you have movement that you don't want. And the main movement disorders are Parkinson's, which is far and away the most common and the one you're most likely to see, followed by Huntington's, which is quite rare, and then hemibolism and Wilson's disease, which are both also very rare. And we'll talk about all these in this module today. So here's a slide that I showed in the module on the basal ganglia indicating where all these different disorders affect the basal ganglia. So in the middle of the screen, Huntington's happens when there's damage to the striatum. In hemibolism, there's damage to the subthalamic nucleus. Parkinson's is when there's damage to the substantia nigra. And in Wilson's disease, you have damage to the globus pallidus and also to the striatum. So we'll talk about Parkinson's disease first. This is a degenerative disease of the substantia nigra, and specifically in Parkinson's you lose dopamine neurons in the substantia nigra pars compacta. When you look at gross autopsy specimens from patients who died and had Parkinson's disease, parts of their brain are actually pale. It's called depigmentation, and that's because they've lost melanin-containing dopaminergic neurons of the substantia nigra. And then it's very high yield to know that the pathologic hallmark of Parkinson's disease is the Lewy body, and this is a picture of a Lewy body down here, and it's an inclusion in the neuron of a molecule called alpha-synuclein. One of the reasons we know as much as we know about Parkinson's is because of a compound called MPTP, which stands for methylphenyl tetrahydropyridine, and it's a compound that destroys dopamine neurons and causes Parkinson's. And in the 1970s, it became a contaminant in some street drugs, and some patients using illicit drugs developed drug-induced Parkinson's, and from that MPTP was discovered, and it's now used in lab animals to induce Parkinson's so that people can study the disease. You need to know the classic presentation of Parkinson's disease, and that's an older male patient. The average onset is in the 60s, so it's going to be someone in their 60s or 70s in a board question. And the first symptom many Parkinson's patients notice is called a rest tremor. It's described as a pill-rolling tremor, although I've never liked that description because I don't think it really looks like a pill-rolling tremor. But in any case, it's a tremor at rest, and you should make sure you know it's at rest because tremors that occur when you're trying to do something are called intention tremors, and that's something else. The second symptom Parkinson's patients get is bradykinesia, which means it's very hard for them to initiate movements. They're sort of stuck and frozen. Once they do get moving, though, the symptoms get better with exercise. It's just hard to initiate the movement. They also have what's described as a shuffling gait. If you ever meet a Parkinson's patient, watch them and they just move their feet a few inches and shuffle along the ground. They usually have a stooped posture. And then finally, they have something called cogwheel rigidity. So if you examine your wrist and you move it around without any resistance, it moves smoothly. In someone with Parkinson's disease, it stutters as it moves from one position to the next, like it's stopping at each of the cogs on a cogwheel. So that's cogwheel rigidity, and it occurs in the joints when you examine them with passive resistance. So there are a lot of drugs used to treat Parkinson's, but what I'm going to try to do is give you a framework to keep them all straight in your mind. So the standard bread and butter Parkinson's drug is called L-dopa carbidopa. It goes by the name of Sinemet, and we'll talk more about that in a minute. This drug gets converted to dopamine in the central nervous system and increases the dopamine levels, and that's the primary problem in Parkinson's is low dopamine levels. Most of these drugs work to try and increase the dopamine concentration inside the central nervous system. Entacapone and tolcapone are COMT inhibitors. They prevent L-dopa breakdown. We'll talk more about those. Selegiline is another drug that prevents dopamine breakdown. Bromocriptine is an older drug. It's an ergot alkaloid. It's a peripheral vasoconstrictor, but it also is a dopamine agonist. Pramipexole and ropinirole are both dopamine agonists. Benztropine and trihexylphenadil are antimuscarinics, but they have some benefit in Parkinson's disease. Propranolol is a non-selective beta blocker. It's mostly used for a tremor called essential tremor, which we'll talk about at the end of this module, but it's sometimes used as a second-line agent to treat just the tremor of Parkinson's disease. And then amantadine you may know as an antiviral, but it also has some properties as a dopamine agonist and also an anticholinergic, and both of these properties help to some degree in Parkinson's, and so you can use it for Parkinson's disease. So let's talk about L-dopa carbidopa, and nobody calls it L-dopa carbidopa, everybody calls it Sinemet. So since dopamine levels are low in Parkinson's, you may wonder why we can't just give people dopamine to increase the levels, and the reason is because dopamine doesn't cross the blood-brain barrier. But L-dopa can cross the blood-brain barrier, and once it gets in the brain, it can be converted to dopamine by an enzyme called dopa decarboxylase. The problem is there is a peripheral decarboxylase that can convert L-DOPA to dopamine peripherally. This limits the benefits, and it also creates a lot of side effects because you have peripheral dopamine circulating. The heart rate can speed up, patients can get tachycardic, and they can feel unwell. You can also get nausea and vomiting from the peripheral L-DOPA stimulating the vomiting center, which is outside the blood-brain barrier. So the way you work around this problem is you give L-DOPA together with carbidopa, which is an inhibitor of the peripheral decarboxylase. This blunts the peripheral conversion of L-DOPA and allows it to cross the blood-brain barrier. In the central nervous system, L-DOPA is good for the Parkinson's because it gets converted to dopamine. However, this is responsible for some of the central nervous system side effects of the drug, and those include anxiety, agitation, and insomnia. To get around these, you use the lowest dose possible. And then one other thing you should know for your boards is that patients taking L-DOPA and carbidopa are sometimes told to avoid vitamin B6. The reason for this is because vitamin B6 promotes the conversion of L-DOPA into DOPA in the periphery. This isn't that big a deal in the modern era when we give L-DOPA together with carbidopa. However, years ago when L-DOPA was given by itself, vitamin B6 was a big problem. And I talk about vitamin B6 and its role in dopamine metabolism in more detail in the biochemistry modules. Sinemet's a pretty good drug for Parkinson's, and ideally we would give it to everybody, but the problem is with long-term use you get a series of motor side effects. One of the problems is that the drug reduces the natural L-DOPA production in the brain so that patients become dependent on the Sinemet. And after they've been on L-DOPA, carbidopa for a while, they start to get this on-off phenomena where they feel well for a while and then they start to get worse. And they get worse rigidity, worse bradykinesia. Sometimes the off can become so severe they get akinesia, where they're basically frozen between dosages. They can also get what's called dyskinesia, where they have involuntary movements that they don't want. So we use the lowest dose possible to avoid this, but the reality is that most patients cannot take Sinemet for more than several years without the drug starting to have serious side effects. Entacapone and tolcapone are drugs that inhibit an enzyme called COMT, and COMT stands for catechol-O-methyltransferase, and this is an enzyme that breaks down L-DOPA. So even though you give the L-DOPA as Sinemet with carbidopa, COMT still breaks down the L-DOPA and limits its benefit. So these drugs only work in combination with L-DOPA. You give them in addition to the Sinemet to try and boost the effect of the L-DOPA. Entacapone is a peripheral COMT inhibitor. Tolcapone is both a peripheral and central COMT inhibitor. The problem with tolcapone is that it's been associated with liver failure. A couple of patients died after the drug came on the market and had to be removed. It's back on the market, but you have to check the LFTs to watch for hepatotoxicity. And this basically makes it a very hard drug to use, and it doesn't get prescribed that much because providers don't want to worry about liver failure and be checking LFTs all the time. Entacapone is used much more commonly. Selegiline is a drug that inhibits MAOB, and MAO stands for monoamine oxidase. Now you may be familiar with MAOA, which is an enzyme that's inhibited by some depression drugs. MAOA breaks down serotonin, so when you inhibit it, you raise serotonin levels, and that can be useful for treating depression. MAOB breaks down dopamine much more than serotonin. Serotonin is called 5-HT. So when you give selegiline, you inhibit MAOB and you increase the central dopamine levels. And this is another drug that's a booster of Sinemet. You can give this in addition to Sinemet to try and raise the L-DOPA levels. And it's got some side effects like nausea and vomiting. It can cause hypotension, and it can cause excessive daytime sleepiness. There are two special side effects of selegiline you should know about, and the first one is the serotonin syndrome. So SSRIs raise the level of serotonin, and then selegiline raises it even further by blocking its breakdown to some degree. So you can get very high levels of serotonin in the brain, and this can cause the serotonin syndrome. The classic triad of symptoms of the serotonin syndrome is confusion, fever, and myoclonus. You can also get something with selegiline called the cheese effect, which is a hypertensive crisis. Certain foods are rich in tyramine, certain foods like wine and cheese and some kinds of meat. And the MAO inhibitors, either the A used for depression or MAOB inhibitors like selegiline, they both block the breakdown of tyramine. So if you eat some of these foods that are rich in tyramine, you can get very high levels of tyramine, and that can cause hypertension. And in the 1980s, when a lot of patients were taking MAOA inhibitors for depression, they would go out and eat a pizza or something like this, and they would present to the emergency room with headache and dangerously high blood pressure. And this was named the cheese effect because that was one of the foods that can precipitate it. And this can happen with the depression MAO inhibitors and also with selegiline. So here's a summary slide I've created to try and help you remember all the drugs used to get L-DOPA into the brain. So what you want to do is give L-DOPA peripherally and have it cross the blood-brain barrier and then get converted to dopamine to help with the Parkinson's disease. The problem is that peripherally L-DOPA gets converted to dopamine, but we give carbidopa to blunt this conversion. Also peripherally, L-DOPA gets converted by COMT to an inactive form, but we can give entacapone or tolcapone to try and inhibit COMT peripherally. Once the L-DOPA crosses the blood-brain barrier, there are two enzymes that can blunt its effect. Once again, COMT can centrally blunt the effect of L-DOPA by converting it to an inactive form, and tolcapone inhibits that. And then also MAO-B can convert L-DOPA to an inactive form, but selegiline blunts that. So how do neurologists use these drugs in practice? Well, there are many different ways, but what I've written here is one of the standard typical approaches. So many patients initially have tremor as their only symptom and their most bothersome symptom. And in this situation, trihexylphenadil works fairly well. It's an antimuscarinic, so it has antimuscarinic side effects like sedation and dry mouth. But if these are manageable, this drug will often improve the tremor for a period of time. Once patients develop bradykinesia and rigidity, the dopamine agonists like ropinirole and pramipexole are often used. And then if those become ineffective, that's when people start to go to the Sinemet. There are some surgical therapies that are sometimes used for Parkinson's, especially in young patients. You may know that the actor Michael J. Fox developed Parkinson's at a young age. And this is a problem because one of the best drugs, which is Sinemet, can only be used for so long before side effects develop. In the past, people tried to do surgeries. One was called a palidotomy, which was partial ablation of the global pallidus. The other was a thalamotomy, which was partial ablation of the thalamus. Nowadays, what people do is something called deep brain stimulation. So they implant a stimulator that delivers high-frequency energy to certain parts of the basal ganglia, and this suppresses neural activation of these areas and improves some of the Parkinson's symptoms. Next movement disorder we're going to talk about is Huntington's disease. This is an inherited condition and it's autosomal dominant, which means that each offspring of an affected parent has a 50-50 chance of developing the condition. It's caused by degeneration in the striatum, and remember the striatum is the caudate and the putamen together. So let's look over here at this coronal brain section on the right. I'm circling the caudate nucleus right here, and the putamen is right down here next to the globus pallidus, and the internal capsule runs between them. So the caudate and the putamen together are the striatum, and that's what degenerates in Huntington's disease. The neurotransmitter hallmark of the condition is loss of GABA neurons. There's also decrease in acetylcholine levels, but GABA is the most important. On brain imaging, the lateral ventricles appear large, and it's very high yield to know that. Let's look over at this picture on the right again. Here's the caudate nucleus right next to the lateral ventricle. So as the caudate degenerates, the lateral ventricles will appear larger. There's also atrophy of the frontal and temporal lobes in Huntington's disease. Huntington's disease is caused by mutations in the HTT gene, which makes a protein called huntingtin. And what happens in this disease is that you get repeats of a trinucleotide sequence CAG. Now, a normal person has about 10 to 35 repeats of CAG, but a Huntington's patient will have 36 to 120 repeats. And remember that it's an inherited condition, so each generation passes on more and more repeats to the next generation. The result is that each subsequent generation gets symptoms earlier. This is a phenomenon called anticipation. What we think happens in this disease is that for reasons we don't completely understand, glutamate kills neurons. This is called excitotoxicity. So remember, glutamate is an excitatory neurotransmitter, and normally it binds to the NMDA receptor and causes a little bit of calcium to go into cells so that you get the neural activity you want. In Huntington's disease, glutamate binds and causes an excessive influx of calcium, and it kills the neuron, and that's called excitotoxicity from glutamate, and it's the mechanism by which we think the neurodegeneration occurs in Huntington's disease. The onset of symptoms is in their 30s or 40s, and in board questions they'll often tell you the patient was adopted, because in real life families that have Huntington's disease always know they have it, and most of the children are tested, and the ones that are going to get Huntington's disease know they have the gene and that it's coming. Death is after about 10 to 20 years. It's a fatal condition, and the symptoms include dementia, chorea, which is dance-like abnormal movements. You should Google this and watch children with chorea from rheumatic fever so you know what it looks like. Aggression and depression. And anytime you see a young patient who's adopted with dementia and abnormal movements, you should know they're probably talking about Huntington's disease. In real life, it's sometimes initially mistaken for substance abuse because the patient is so aggressive and depressed until later they realize they have Huntington's. There's no cure for Huntington's disease, but you can treat the symptoms. So dopamine is associated with the movement component of the disorder, the chorea. So if you block dopamine, you can reduce the chorea. And there are two drugs that are used for this, tetrabenazine and reserpine. Both of these inhibit VMAT, which is vesicular monoamine transferase. It's what packages dopamine into vesicles so that it can be released by neurons. And if you don't ever let it get into the vesicle, then it doesn't get released in the central nervous system from neurons, and you reduce dopamine levels, and this helps some of the chorea. You can also use Haldol, which is also called haloperidol, which is a dopamine receptor antagonist. Next movement disorder is hemiballism, and this is wild flinging movements of the extremities on half the body. You may know the term ballistic, as in to go ballistic means to thrash around wildly, so this is like being hemiballistic, or having ballistic movements on only half your body. It happens when there's damage to the subthalamic nucleus, and this is seen in very rare subtypes of lacunar strokes. Wilson's disease is a disorder of copper metabolism where you get accumulation of copper in the tissues of the body, and one of the places where lesions occur is the basal ganglia. You get damage to the putamen and the globus pallidus, and remember the putamen is part of the striate, so sometimes we say the striatum and the globus pallidus are affected in Wilson's disease. There are many symptoms of this condition, but the ones that pertain to us now are the movement symptoms. So these patients can get Parkinsonian type symptoms like bradykinesia and rigidity, but the classic symptom is called a wing beating tremor. So patients who have this, when they clasp their hands together in front of them and lift their elbows to the side, their arms will beat like the wings of a bird. You can go to YouTube and watch someone who has this, and if you see a board question with wing beating tremor, they are talking about Wilson's disease. The most common neurosymptom is dysarthria, so it's difficult to get the words out. Patients have slow, irregular speech. Let me mention some other movement disorders that you should be familiar with. So chorea, we mentioned, can happen with Huntington's disease. It's random purposeless movements. It's sometimes described as snake-like. You can see pictures of this on YouTube if you want to know what it looks like. And this happens when there are problems with the basal ganglia. Athetosis is a slow writhing movement of the fingers. Patients turn their fingers over and extend them uncontrollably. And this also happens with basal ganglia problems. Myoclonus, many of you have probably experienced when you're falling asleep and you suddenly have a jerk of your leg or arm. It's a sudden one-time muscle jerk or contraction. And this can occur in a number of conditions, and it's common in renal failure and liver failure patients. And then finally, dystonia is a spectrum of conditions. It literally means abnormal tone. And these patients can have a contraction of a muscle that's sustained that they can't release, or they can have repetitive contractions of muscles like twitching. And it can be focal, for example, just in the hand, or it can be more diffuse, where they have contraction of their neck and shoulder and their legs. There are many different types of dystonia, but two that you should know are writer's cramp. So some people, after they've been writing for a period of time, find their arm or wrist spasms and they can't relax it and they're no longer able to write. And then blepharospasm are people who have twitching of the eye muscles. Some of them blink uncontrollably or have their muscles clench up and close their eye, and it's hard to get it opened again, and that's called blepharospasm. Let me just mention the two most important causes of chorea that you should know. The first is Huntington's disease, which we've discussed, and the second is acute rheumatic fever. And obviously the history here is key. If they describe to you a child with a recent sore throat who has chorea, that is acute rheumatic fever. On the other hand, if it's a person in their 20s or 30s who has dementia and aggressive behavior, then they're talking about Huntington's disease. Make sure you know the different types of tremors and the circumstances in which they occur. So essential tremor is its own disorder. We'll talk about that in a minute. And this is a tremor that occurs with intentional movement. Resting tremor is what you usually see in Parkinson's. It's usually the hands. It gets better with intentional movements, and it's described as pill rolling. Intention tremor is what you see in cerebellar dysfunction. So when you perform a physical exam, you ask a patient to touch their nose with their finger and then touch your outstretched finger and go back and forth. Patients with cerebellar dysfunction can't do that. They zigzag when they try to get towards the target. This is called dysmetria. It means they cannot measure their movements appropriately, and that's what you see in cerebellar dysfunction. And then finally, wing beating tremor is really rare, but this is what you see in Wilson's disease. And as I said before, it's where the hands are clasped together and the elbows out and they flap their arms like the wings of a bird. We'll finish this module by discussing essential tremor, which used to be called benign familial tremor to distinguish it from Parkinson's. It's a tremor that occurs with intentional movement. It has a genetic predisposition, so many patients will have a parent or grandparent who also had essential tremor. It's high yield to know that alcohol helps, so many of these patients will self-medicate to make the tremor go away. And you can treat this with propranolol. The mechanism of benefit is not clear, but it's very effective. Also, a drug called primidone is effective. Its mechanism is not clear. It gets converted in the body to phenobarbital, but when people try phenobarbital, it doesn't help for essential tremor. So it's something about the primidone itself. But either of these two drugs can be used to treat essential tremor. And that concludes our module on Parkinson's, Huntington's, and movement disorders.